As mentioned, my name's Alex. I'm an analyst at the Health Foundation. And as you might guess, we're here to talk today about the use of latent profile analysis on, in this case, general practice staffing data. So the overall kind of aim, I suppose, is to describe different practices' approaches to staffing, whether that's more or less of a focus on one staffing group versus another. So as we kind of mentioned, it's a relatively new method, so we'll kind of cover a little bit about the basics of what it does, and then kind of walk through the process of creating a model, and then indicate what types of findings you can present with that. So the highly imaginative structure is going to look like a bit like this. We'll spend a little bit of time talking about the process we went through to derive FTE, rather than using headcount or kind of activity data. Because there's a bit of work we had to do before, in terms of kind of data preparation, before we can feed that into our analysis. And as I mentioned, we'll then kind of follow through, look at findings and discussions. And I noticed that on the Menti there wasn't an option for primary care, but it doesn't seem like there's a huge amount of staff from primary care settings, but at the same time, everyone has an idea of the context facing kind of primary care, as you know, if nothing else, from a patient perspective. But it can broadly be described as, and similar to other healthcare settings, an increased demand for primary care at the moment, with fairly significant workforce pressures. So there's a few things that are occurring to create that kind of situation. First being a failure to meet a couple of recruitment targets in terms of GP staff, occurring alongside a fairly natural change in GP workforce. There was a reduction in partnered GPs, so the kind of more senior qualified GPs, whether that's through kind of cohorts retiring or through moving away from partnership models in general. And there's also an increase at the moment in GP staff working less than full time, so the proportion of GP staff that are doing 15 to 37 hours or so is increasing. So that all equates to less, or a bit of a change in the GP workforce. Alongside that, that cocktail is an increased demand for care through kind of population levels, i.e. population demand for care through sickness and age, but also through kind of top-down and bottom-up effects, I suppose. So you can see through kind of NHS waiting lists, pressures in the secondary care system, there's a kind of overflow of demand for care on the primary tier there, and similarly the same type of thing happening through kind of issues and inefficiencies in social care. So all equating to reduced access to GPs at the moment. So at the moment there are more patients per GP FTE in the kind of country than there has ever been. As we mentioned at the start of the meeting, one of the approaches to addressing that is the additional roles reimbursement scheme, which incentivizes practices to utilise non-medical members of staff. So there's, I think, 18 roles considered within the additional role scheme at the moment, generally that fall within kind of allied health professionals, other health professional type categories, so pharmacy technicians, GP associates, social care link workers, that type of stuff. So we'll try and keep that policy in mind when we work through the results and the discussion. So with that, our kind of study aim was to initially just describe staffing trends in a descriptive format. The results of that phase of the analysis are elsewhere at the moment. I can send those over to Rachel to disseminate, but the focus of today's session is going to be the study aim 2, which is how to utilise cluster analysis to identify these staffing configurations and then link those staffing configurations to demographics at the practice level. So the data we're using is primary care data. It's CPRD Aurum data. So the CPRD data covers around 40% of the practices in the UK. So it's obviously fairly broad. Our sample within that consisted of 27 million patients over 1,500 practices, which then delivered somewhere around 2.7 billion contacts in this sense. So traditional consultations, but also administrative non-patient facing kind of actions as well between 2015 and 23. Broadly, our sample was kind of representative at the regional and deprivation levels. You can see kind of the table type output there. So a couple of regions were kind of slightly under or slightly overrepresented, but nothing that fundamentally adjusted what we were trying to achieve. So as I mentioned, we did a bit of kind of data transformation before feeding our staffing data into our model. So the raw data exists in the form of a consultation table. So each row is a consultation, whether that's patient-facing, patient interacting or not. So each row has a contact ID and the staff kind of pseudonymized person level staff ID of the member of staff that delivered that. So we then link our staff codes to like a CPRD staff table, which then gives us more details around what their actual job role is. So within our data, we had 250 or so distinct kind of job roles. So, certain types of medics, certain specific types of nurses, that type of thing, which we then group into 6 broad staff groups. So we had 3 medical groups, the first being fully qualified medics that were permanently employed. So things like GP partners, salaried GPs. The next being fully qualified, non-permanently employed GPs, so sessional and locum GPs. And the third medical group being junior doctors across the broad span of the junior kind of status. And then we had a category for nursing staff, a category for healthcare assistants, so generally unregistered kind of band 4 and below type positions, and then another category for healthcare professionals, so AHPs, pharmacists, social workers, that type of stuff, including advanced practitioners in that group. So there are 6 kind of broad staff groups. So if we start by summarizing or grouping our data, our contact data, and counting the number of contacts per practice per staff group, and obviously within that it was possible for us to use a headcount measure, which would obviously require no transformation, but given the inherent weaknesses that we were aware of in using a headcount, specifically, we know that a lot of primary care settings utilize part-time members of staff or members of staff that work across different practices. We expect that the effect of that would be to kind of artificially increase some of our staffing levels. So try to derive an FTE measure from consultation activity, which is a relatively new approach. So very much open to feedback on this section. So we start to do that process. We have to essentially define in the units of consultations what number of consultations equates to a full-time day of work for a certain member of staff, so that we can divide our contacts by that. So we knew that the number of contacts that each member of staff do in a day is going to vary by, first of all, by job role, given that the types of patients they're going to see and the level of complexity that those patients are going to present with is going to differ. Some GPs might see 5 patients in a day, and that would be a full-time day of work. Some might be working with less complex patients and therefore see more. We also expected that the number of patients that a certain member of staff can see in a day is going to vary by demographic factors, particularly deprivation and ethnicity mix within the patient list population. So we sampled 10,000 members of staff, plotted their total daily consultations, and stratified them by demographic factors, and then extracted the 75th percentile of that curve to operate as our estimate of full-time working. So that then gave us essentially a lookup table of per staff group, per ethnic proportion of patients from ethnic minorities, kind of quintiles, and deprivation quintiles, an estimate that's stratified by those variables, which we can then pull back into our activity data, again, just kind of by simple left join, pull in the specific stratified estimate of full-time that we need, and then we can divide our contacts at the group level by our estimate of full-time to give us something resembling an FTE proxy. So we can, the first step we took at that point was to compare our FTE proxies to our headcounts, just as a bit of a sense checking exercise. And we can see that, as you expect, the FTE proxy line, the red line there, the values are quite a lot lower than our head count, suggesting that there are number of members of staff across the sample that are doing less than kind of full-time working, but broadly follow similar trends, and therefore, it's a kind of valuable exercise to work through, we thought. So that essentially gave us a table of all of our practices, our 1,500 practices, one row per practice, and then columns for each of our staffing FTE levels, summed across our data collection period. So prior to feeding that into our latent profile analysis, we converted the FTE sums to an FTE rate, just to account for any kind of variation in practice size to start with. Removed a few of the outliers to kind of ease the modelling, and also performed a couple of descriptive analyses. And then at that point, we were ready to feed the outputs of our FTE derived measure into our latent profile analysis. So I'll just talk a little bit about what actually that is to kind of contextualize latent profile analysis alongside other types of cluster analysis. So the definition there is fairly wordy. It's a finite mixture modeling that applies probabilistic modeling techniques to allow a user to determine unobserved or latent groups within a population. So the key aspects of that definition, I feel, are the fact that there's a probabilistic modeling going on. So data points are assigned in a probabilistic way, and there's an assumption of unobserved or latent groups. So not to throw you all back to a biostats lecture theatre somewhere, but each quadrant here is one of the broad types of cluster analysis. So I'll just change this actually so you can see. So LPA falls within the model-based clustering. So a key feature of model-based clustering and LPA is that points are assigned to clusters based on their distribution. So the model assesses the distribution of all the points in the sample, looks for shapes that the clusters are occurring in, and then will, using probabilistic kind of assignment, will then assign a point to a cluster based on its position relative to the other points around it. Whereas something like k-means clustering or k-medioid clustering, which is a distance kind of a method of clustering analysis that is driven by the distance a point is compared to or relative to a central point of that cluster. So in that sense, k-means clustering would assign this blue point here to this blue cluster because the center of the kind of central measure, the kind of mean of this cluster here, is closest to this point relative to any of the other central points. So it's looking at the observed variables. Whereas, for example, within a probabilistic assignment, this point here, for example, I don't think necessarily is on this image, but theoretically this point here could be closer in distance to the central point of this blue cluster, but given its position relative to others and this kind of shape in which they're occurring, it's kind of probabilistically assigned to this cluster. So that's the kind of key difference in terms of how they're assigned, and the way in which the way that the model can do that is a function of its kind of fundamental assumption that there are unobserved factors in the data that are responsible for the clusters rather than just those that can be measured. So essentially that's where the kind of latent profile, the unobserved side, comes in. So if we're having selected our kind of clustering method of choice, our LPA, we then fit all kind of possible LPA models to our data and are then steered by goodness of fit measures as to which of the specific LPA models to choose. So the various approaches that you can take within LPA are essentially just different functions of the types of shapes that are present in the data, the shape, the distribution, the volume, the kind of variation that is currently there best fits one model versus another. So in this situation, we're trying to identify the lowest BIC score, a goodness of fit measure. So you can see that our dark green line here offers the kind of the best goodness of fit measure relative to other approaches.
So we at that point select the VEV kind of episodal equal shape model. At that point, we also have to make a decision as to how many profiles to extract from the data. Do we want our data to be split into 3 clusters or 4 or however many? And that's a trade-off between kind of trying to achieve model simplicity or kind of to reduce the complexity in our model. So go for less profiles and potentially have better interpretability when we feed back the results. Or as we increase the number of profiles that we select, essentially you're certainly going to improve your goodness of fit measures, because the more models they are, the more the data fits. The more profiles they are, sorry, the more the data fits to those profiles. So we select the VEV model with 6 profiles because that offers the best BIC score and also a certain amount of granularity, and while maintaining the interpretability of the outputs. And that's kind of supported by kind of more in-depth goodness of fit measures, like things like bootstrap likelihood ratio tests and a number of other things you can apply. So that's kind of, at that point, that's where the model stops modeling and kind of hands the results over to you as the analyst to derive some meaning from and to compare profiles against each other. So the model generates mean staffing levels for each of our profiles. So for example, if we identify this dark green line, which is in this case model profile 4, we can say that the profile 4 has above average staffing levels in each of our 3 medical groups, below average staffing rates in our nursing and healthcare assistant group, and above average healthcare professional and advanced practitioner staffing levels compared to other practices in our sample. So the relative levels of staffing are the things that define our models in this sense. So for that profile, we might conclude that it's, the way to describe it is that it has a medical focus and also perhaps a healthcare professional focus. But you can see where there's a certain degree of science and art clashing here, and it's a kind of a human process to go through where you assign the profile names, because that then shapes how they're interpreted results-wise. But so we do that for each of our profiles, and broadly, each of our practices fits into one profile only. And our profiles can be described as either having a high overall staff rate. So practices in this profile have above average staffing scores in every measure. Focus of medical staff compared to other groups within that profile, but compared to other profiles, they're high staff rates. The next 2 are defined as kind of having quite low staff profiles or staff levels, apart from relying on either one type of medic versus another. So profile 2 is kind of low in all staff groups, but reliant on these partnered and permanently employed GPs, compared to profile 2, which is similarly low in all staff groups, but is reliant on non-permanent medics, so locums and sessional GPs. Profile 4 we mentioned, which is kind of high medic and high healthcare professional relative to other practices, but low nursing and low healthcare assistant levels. Profile 5 is almost the inverse of profile 4, where you've got low qualified medics, that is, and high nursing and healthcare assistants, but alongside increased rate of junior medics. And profile 6 is just a non-medical focus. So low medics, all 3 types of medics are below average compared to other practices or other profiles. And there's an emphasis on non-medical staff. So that's essentially the results or the output of the cluster analysis. It's a tool that condenses 5 or 6 measures of staffing levels into one single metric, which we can then apply and link to other kind of variables of interest. So just at the high level, each of the kind of distribution of practices within our profiles looks a bit like this. So the least populated profile in terms of practices is the high overall staff rate. So they exist in the data, but not at particularly high levels. The most kind of populated profile is the low overall staff rate with the reliance on fully qualified permanently employed medics. So just to remind you, that was this one. So this is almost the default. You can almost consider this the default approach to GP staffing. at the moment, given it's the most common. And then the rest of the profiles are kind of similarly populated, which is a kind of a tick in the box for our kind of model, I think. So in terms of ways to apply those findings to kind of broader metrics, we can link our profiles to our practice deprivation scores, and we can assess whether any profiles are over or underrepresented in terms of deprivation. So our all of our practices are distributed according to deprivation like this. So relatively evenly, but kind of slightly increasing as affluence increases. So there's a this is a kind of fairly quick and easy tool to eyeball differences. So there's a couple of things you might point out, but if we focus on practices that utilise non-medical staff, we can see that they are underrepresented in the most deprived quintile of the practices, but overrepresented in the most affluent, which almost goes against this trend that the more deprived areas are kind of under-doctored. This finding might suggest that actually the more affluent areas are the ones that have non-medical approaches, and the more deprived areas are the opposite, essentially. So it might even be adequately or over-doctored. We can also apply the same kind of approach to our measure of patients from ethnic minorities. So this measure is essentially the proportion of patients on the list that are from ethnic minority backgrounds. So practices in the lowest quintile are essentially the least diverse practices, and the practices at the higher end of the spectrum are the most kind of ethnically diverse. So we can see that in terms of practices that are more ethnically diverse, they're overrepresented in practices with a low overall staff rate and a reliance on non-permanent medical staff. Inversely, practices that are least ethnically diverse are overrepresented in practices with a profile with a staff focus on kind of nursing and junior medics. We can also invert that measure, and we can, instead of looking at the distribution of a certain metric within our profiles, we can look at the distribution of our profiles within a certain metric. So in this case, we can assess the regional split of profiles. So at the national level, our profiles are organised, as we mentioned, as the kind of least populated one is the high overall staff rate, and the kind of most populated one is the low overall staff rate with reliance on permanent medics. So in terms of the distribution of practices with a high staff rate, we can see that North West and Yorkshire have a kind of more than their share of high overall staff practices compared to the South East and South West, which are relatively underrepresented on that measure. The East Midlands has no practices that are considered a high overall staff, and has more than you might expect of practices with a low overall staff rate and a reliance on one permanent medic. So these types of tools can obviously identify a kind of high level evidence of inequalities, which can then be obviously analysed further. And we also pull the results back into the perspective of the additional roles scheme. So as I mentioned, the additional roles covers a handful of non-medical professions. So if we plot contact rate in those roles at the practice level and split those out by each of our staffing profiles, we can see whether one profile compared to another is more likely to utilise additional role staff. So as you might expect, the staff profiles that prioritise non-medical staff are more likely to be utilising the additional role members of staff. The two are correlated in that sense, so it's not a huge groundbreaking finding that the three profiles that are kind of more prominently employing non-medical staff are also going to be delivering more additional role care. But at the same time, the range of values within each profile is fairly similar. So each profile that we have shows evidence of very high utilisation rates for additional roles and also very low, which is kind of indicative. These two roles, for example, that have a reliance on medical staff and under kind of below average levels of healthcare, of broader healthcare professionals, some of them still do achieve very high levels of additional role utilisation. In terms of a couple of quick discussion points, as we mentioned at the start, it's a relatively new approach. It's, kind of like in line with the trend of cluster analysis not being the easiest or the most regularly utilized tool in kind of operational analytics anyway. It's obviously quite prevalent in academia, but as Rachel mentioned, it's not something that we as analysts can do very often. So given that kind of context, it's not overly surprising that a somewhat niche version of cluster analysis is also similarly underutilized, but hopefully this can contribute to a growing body of knowledge and kind of hopefully inspire some people to try and utilize it, because it is a valuable tool. Given as well that it, the output of that tool is essentially a metric, it's very easy to utilize further. So you work through a process of condensing a number of variables into a single variable, and if that's done properly, you can then quickly apply that cluster measure to other questions around deprivation. Or the initial plan for this piece of work was to apply this staffing measure to kind of clinical and kind of operational data. In terms of areas where there's kind of some subjectivity and some very much open to feedback or criticism, is our process for deriving FTE is fairly novel, I think, and identifying or extracting the 75th percentile is a somewhat arbitrary figure. The reason that we selected that figure rather than taking the kind of the max, I suppose, is that we know that on one end of the spectrum, lots of members of staff are working less than full time for a single practice, given their working hours or their employment at PCNs across various practices. But we also know that a lot of medics or primary care members of staff are technically kind of overworked in terms of doing more than full time. So in that case, using a more traditional FTE measure where kind of 1 is the max would blur some of the granularity in that side, that end of the spectrum. But similarly, if we chose the 60th percentile versus the 75th or the 90th, the overall relative differences between the profiles would be the same. It would just be occurring at different volumes. So the findings, I think, are relatively unaffected, but as I say, very much open to discussion on that side of the process. And similarly, there is subjectivity with every cluster analysis, I think, in terms of how you apply and interpret and then apply the clusters that a model offers you. So it may be that our process by which we went through the naming of each of our profiles might be inaccurate potentially, or might blur some of the findings if we focused on one professional group compared to another, for example. But I think those types of things are fairly universal to a lot of cluster analysis. I hope that wasn't too quick. I think that is all I've got.
That's all I've got. Well, okay, top tip: don't end it like that at Hacker. That's all I've got. Off you go.
I mean, no, that's kind of the truth.
No, that's great. Thanks very much, Alex. Thanks for talking us through the work, and hopefully it's useful to sort of explain it in that kind of way. Because I think once you've done it, it starts to make sense to you as well. Look, we're getting loads of thumbs up. Thanks very much.
I can't see it, but
well, there you're getting claps and thumbs up all round, Alex. It's gone down very well.
Good.
I would, yes, and if anybody has got any sort of feedback that they want to just share afterwards, then I'm sure it'd be very welcome. Yeah, that is actually a fair point. Somebody's put in the chat, I don't know whether you can see the chat, Alex, they've just said it's really good. There's actually quite a lot of information to digest before asking questions. And I've found that as well. If it's a new topic, you want to engage, you want to find out more, but you also don't want to ask a stupid question. I mean, I'm
almost certainly not anyway an expert on this, so I'm only a couple of months further down the line in terms of I pick this up from cold as well, so if you have a stupid question, I'll probably also ask it myself.
Excellent. Nathan's got his hand up. Nathan.
Thanks. Hi. I am an analyst with the Black Country Integrated Care Board, and my specialism is primary care workforce. So I have lots of questions. I thought this was a really interesting analysis actually, and it's great to like see a new technique and see it being applied to some an area of work that is something I'm familiar with. So that's really interesting. So thank you for that. The question at the top of my list is, why did you decide to derive an FTE proxy rather than using the data from NWRS? And also, did you do any comparisons between your FTE proxy and the published NWRS figures?
So we, as you say, there are kind of publicly available FTE measures which we were kind of aware of, but given that this occurred within CPRD data, the initial plan was to link the results of these findings to kind of data that's only captured within CPRD. So we couldn't bring anything from the external environment in because of the kind of way in which the data is stored and accessed, and we couldn't link our practices to any of the publicly available FTE kind of workforce type data. So we were kind of forced with either essentially use the headcount that was in the data or try and recreate it, and hopefully you agree that it was preferable to do that rather than use headcounts. So
yeah, absolutely.
Yeah. So essentially, it's kind of a limitation, I suppose, of the format in which we're interacting with the data, given that it's broad and very rich data. It's very kind of heavily protected. In terms of comparisons externally, we could only do that at a very high level, kind of essentially with like two screens alongside each other, because we couldn't export the findings in that sense. So we could compare internally to the headcount trends at various levels, but it was somewhat limited in terms of comparing. It would have to be like the national picture within our data and the national picture in the external public data. So we tried, but it was difficult.
Okay. Thank you. That makes absolute sense, given the limitations that you were faced with. The limitations themselves might not necessarily make sense, but yeah, that's great. Thank you. I suppose my immediate kind of concern about the implications of that for the analysis is that the way the workforce is organised in primary care can be a real head scratcher sometimes, and there are so many kind of like local arrangements whereby different groups of staff are employed by different organisations, but they actually work across other organisations and all of that kind of thing. So you're trying to get a picture of what the workforce looks like based on the activity recorded in each practice's appointments book. But it's not necessarily the case that all activity that occurs with patients from that practice will be recorded in that practice's appointment book. For example, if there are some staff operating at PCN level, running PCN-wide clinics, and patients from multiple practices attend those clinics, then those attendances, those contacts aren't necessarily going to be recorded in the appointments book of their own practice. But I think that's just a limitation of the data set that you're working with. You can't really see those relationships. And I don't know how you get around that one, unfortunately.
Yeah, no, I think that's totally valid. We did try to link to kind of pull in PCN indicators into our data and potentially perform some of this analysis at the PCN level, specifically around the additional roles kind of rates, given that they're quite small in comparison to the other staff. But we kind of wanted to ask questions around of the practices that are utilising these additional roles, which are they focusing on? Are some of the additional roles often seen coupled with some of the others compared to that type of those type of questions? But again, we weren't able to pull in PCN because it was a kind of a risk of disclosure essentially. But
Yeah,
that's definitely, I think, just a limitation that we can't tap into PCN clinics that are occurring at that level and recording the appointments being recorded there. We kind of hoped that by looking at the activity or kind of deriving staffing from the activity, that it would include those members of staff that work across practices at a level proportional to kind of what they're actually doing at those practices. But as you say, it also does then just kind of outright exclude admin staff that are working on kind of patient-related care that might not be directly related or directly patient-facing, but is certainly related to the care that they're receiving, communications and whatever.
Yeah.
But that was essentially the decision we made to exclude.
Yeah. I have one more comment, if I may, and then I'll let somebody else speak. But I think the staff groups that you've used, I think make sense. But I think as somebody working in primary care with primary care workforce, general practice workforce, I think what would be really interesting to see is what's the kind of split or the breakdown between those practices who have what I might call it, they're very focused on a kind of a medical model. So they're heavy on GPs, but then they're also heavy on those other direct patient care staff who support a sort of medical model of care. So I'm thinking of like clinical pharmacists in particular and physician associates, versus those practices who are adopting perhaps more holistic approaches to care that might involve, for example, the more involvement with the personalised care roles, social prescribing link workers, health and wellbeing coaches, stuff like that. That will be really interesting to see. And I think the technique you've used here could be used to explore that question. So yeah, just a kind of suggestion, if you happen to get any more funding to do some more of this,
thank you.
Then that would be a really interesting question to explore.
Yeah, so that would just be a case of essentially reassigning our healthcare professional roles to a kind of a model approach rather than. Yeah, that's interesting. Thank you.
As you were saying about the subjective groupings, I mean, I think the ones you picked are perfectly valid, but you could pick other groupings and answer different questions.
Yeah, certainly.
Steve, thanks, Nathan. Over to you, Steve.
Thank you.
You're on mute, I think, Steve.
Thanks, Alex. Thanks for doing the presentation. I was just thinking about wider application of the clustering now that you've developed it. It would be really good to be able to use it outside of the CPRD environment. And I'm just wondering if there's some way you could almost provide a set of rules that could be applied to assign practices to a cluster based on their characteristics. Now that you've derived the clusters, could you give us a set of rules which said, if a practice has a skill mix that looks like this, then they tend to belong to this cluster, so that we could then apply the clustering that you've developed to data sets outside CPRD and answer questions that might be of interest to lots of other people, for example, about the relationship between skill mix and satisfaction or continuity of care or patient outcomes, for example. Do you think it might be possible to almost derive an algorithm which assigns practices to one of your clusters based on a set of rules?
It would have. I mean, you'd presume so, and it would have to be. It would just be a case of essentially kind of reverse engineering, looking at because essentially when every practice is assigned to a cluster, it's given a certain probability, and you could, I think, reverse engineer the various staff levels, the kind of scaled staff scores, and to kind of position them. It would be, I think, quite manual, I guess, but I don't see why it couldn't be possible. It would probably take a bit of thinking around, and it's not something we've tried to do for this piece of work, obviously. But yeah, that's definitely, I think, a good area to explore, as you say, in terms of broadening the findings and getting around applying it to other data sets.
I think it'd be incredibly useful if you could do that. I know it's extra work, but it means that there's sort of wider applicability of the work you've done, really. People can then start using the clustering without needing to access CPRD, for example. The other quick question I had was about the rates you calculated. So presumably these are staff numbers per head of registered population or something like that. Are these just crude rates essentially, or were you weighting patients by some way to take account of their needs? What was your thinking when you came up with your rates?
They're relatively crude. They're not weighted by kind of need or demand. It's more just the denominator is patient population years. So just kind of weighted population based on their registration throughout the year.
Yeah. Do you think it's possible to have a weighted denominator? I'm just thinking that I'm trying to work out how that might affect your results, because those practices that have relatively low staffing levels might be those with lower levels of need, for example, particularly young population. And I'm just wondering if it might move practices between clusters if you had adjusted for need in the denominator.
I suppose it's one of those things that it's hard to know. It's probably worth doing without knowing how it might affect the results anyway, right? If it is going to just offer a more valid image of the denominator, then maybe it's worth doing. I don't know exactly how it would, whether you'd see much of a shift. It might be relatively small, but yeah, it's probably worth looking into, I think.
Even just age and sex adjusted would be that would do most of it, I think, wouldn't it?
Yeah, just as proxies for wider need. I'll make a note, Stephen.
Thanks, Alex.
Thanks, Stephen. Yeah, no, I think that's a good idea. So before you do your presentation at Hacker,
like 2 weeks or something.
Yeah, 2 weeks, no pressure. But I think it might just be useful to say some of the things that you're going to be maybe working on to develop it. I don't know whether this is ongoing or a complete piece of work, or whether you have the opportunity or resources to actually sort of make some refinements to it, sort of based on what you heard today. But I think that would be really useful, actually, doing the age sex adjustment. And I think your point and Nathan's point also about the subjectivity of the naming of the clusters, it's a funny thing, isn't it? Once you've created those names, that label, that is quite sort of is in people's heads. That's it. That's the label, and it kind of it leads people down a certain route in terms of how to interpret the results. Obviously, that's why you do it. But if you are describing something, a range of roles, or the way that GPs are have arranged their services and support and everything in a more traditional way, that won't necessarily fit with a GP practice, which may be going down some of the things that Nathan touched on, maybe a non-traditional way, and having a lot more sort of support from other people in providing services in different ways, in a holistic way, and health and well-being, kind of more prevention and all that kind of stuff. So you can't factor everything in, but I think it is important to. And I liked the idea of having a sort of a discussion around what that naming is, because that's the basis of everything, isn't it? If those are it, if you review them and other people sort of look at them and think that's it, then it's the work to do to back engineer and get those sort of criteria to spread more widely, that Stephen's just been talking about, would be the way to go. But if in fact, we just might need to just check that those are the categories that we want to be doing all the further analysis on, that's interesting too.
I suppose it's something that, like, analysts, or maybe just myself, are not particularly comfortable with, shifting your brain from kind of focusing on the numerical outcomes and being led by the data to being almost a little bit creative, and there is the fear that you're going to prime the kind of the reader or the person who's digesting the results to one, as you say, one way of thinking versus another, which could be intentional, could be unintentional, and it's generally best to it's easiest just to be super plain about it and say this profile is lots of this and not lots of this. But if you can, as Nathan kind of alluded to, if you can try and link them between what they're seeing and like a staffing approach or a model or like some type of like broader kind of level of thinking, then that can actually advance the findings, but it's not the easiest.
Yeah, I think anything to sort of help people understand the results and see how they can be applied, and just do something with them, whether they can be applied in different scenarios and linked with different things and so on. I think that would be really useful. Nathan in the comments is asking if there's an R package that can be used for latent clustering analysis. In fact, is that what you used?
Yeah, I think it's called MClust.
Right. Okay. Great, that's useful. So we're approaching the end. There are one or two unanswered questions, Alex. So in my time-honoured way of chairing sessions very badly, I'm probably going to share those with you after today's session, if that's okay.
Yeah, no,
Generally, thank you ever so much for coming out. I have just got a little bit of finishing off to do before, but thanks very much for coming. I will see you at Hacker. I'll be there for the 2 days. I'm doing something. I think I have a role. I think I'm interviewing people, and I'm doing some various other things as well. I also have a session with Mohammed in one of the workshops, which is going to be, well, obviously the second best session there.
Thanks for having me.
No, that's great. Right, so I'll send those to you after, if it's okay. If you could just respond to them, and I'll pop them on the website with the recording. So I'll just move on. I'll just share my screen again, just to finish up, and then we'll just, if people are still around, we'll say why I am in fact linked to Jamie George. So those were the questions which I'm just going to move on from. Oh, actually, I'm going straight in with it. So, Alex, why am I Jamie George in your eyes?
I don't know if there's a way of describing it in a family link way, but essentially Rachel's dog is the sibling of Jamie George's dog.
Yeah.
Jamie George being the England captain and perhaps a lion next year. So.
Yeah.
Big
So
fans,
that's it. So I don't think there's an IG thing going on there. Obviously I hang out with Jamie all the time as a result of this. My husband's a big rugby fan, and none of that bit is true, because he's just be scared stiff to reach out to him because it means too much. You know how that happens. Okay, that's my dog anyway, and he's not like that now. He's a big 35 kilogram softie basically. So I'm going to stop sharing. I'll come back to the room, and I thank you again, Alex. See you in a few weeks, and I'll see everybody else either at Hacker. No, in 2 weeks. No, it's still before Hacker. We can do this. I can work out numbers and dates. I'll see you in a couple of weeks, everybody. Thanks very much for coming. Okay, bye bye.
Thanks, Alex. Thanks, everybody.